It has been shown that access to rehabilitation is significantly challenging whether it has been in a high-income country or a low to middle-income country. It's only been the facilitators or the barriers that differ between the two. These factors are things like resources or infrastructure, and that is just to mention a few. Although recent research, which has mostly been done in high-income countries, has shown that technology use, which is known as telerehabilitation, has been successful in assisting with access to rehabilitation, specifically in the more older or chronic condition populations. Telerehab provides remote rehabilitation care through technologies such as video conferencing, smartphones, and internet-connected devices, which means it improves accessibility for underserved regions and offering patients increased flexibility to accessing the healthcare. Despite its potential, the adoption of telerehabilitation is impeded by several factors, including limited technological resources, high costs, lack of digital access, and insufficient healthcare systems. These challenges have collectively hindered the implementation and acceptance of telerehabilitation services in the healthcare settings of low to middle income countries. Therefore, we decided to look at the perspectives of osteoarthritis patients in using technology in their rehabilitation. OA was used as it was seen as one of the most or major common chronic conditions seen in South Africa's rehabilitation settings. Therefore, we wanted to see how our OA population would find using technology in their rehabilitation. Would they be keen, or do they even know that these services are available to them? Our objectives looked at the awareness about the use of technology as part of their rehabilitation program, their views on accessibility to any device, and affordability of digital technology, their willingness to accept technology as a mode of delivery, and just their keenness for OA technology in their OA rehab. As a secondary objective, we just briefly wanted to describe the sample of the population with respect to their function, their quality of life, and their self-efficacy. The study had a qualitative descriptive study which had a minimum of 10 patients or participants, and data saturation was met with a minimum of 10 participants. We used semi-structured interviews and patient-reported outcomes to gather our findings. And then the study was done in a public community center in the Cape Metropole, which is in Cape Town, South Africa. Our results showed 4 main themes, which was telerehabilitation awareness, the benefits of telerehabilitation, and implementation considerations, and then the future use of telerehabilitation. For awareness, participants showed limited awareness and minimal digital literacy. Most had little to no experience using online health resources, preferring more traditional methods of learning about their condition, which is gaining the information from peers or directly from the health professional. This highlighted a significant gap in the digital health literacy among our participants in South Africa. For benefits, despite initial skepticism, participants recognized several benefits of telerehabilitation, including improved access to their healthcare professionals, educational information, and the convenience of receiving services from their home. This is also important as the participants reported high levels of pain and low self-efficacy, which affected their daily functioning or their ADLs, which is just their activities of daily living. Implementing telerehabilitation could enhance their quality of life by offering better access to healthcare providers when support or guidance on symptom relief are needed, which is very important when it comes to osteoarthritis, which requires maintenance throughout the journey. The flexibility and time efficiency of telerehabilitation were particularly appreciated, as was the potential for family involvement in their rehabilitation journey. For implementation of telerehabilitation, there was mixed views. While some were open to learning and using telerehabilitation. Others preferred in-person interactions due to concerns about the quality of care and the therapeutic relationship they need to have with their therapist. Privacy and data security were also important considerations for the participants, specifically because of our healthcare settings and the contextual factors in our setting, South Africa. For future use of telerehabilitation, the study revealed a generational divide in attitudes towards technology use. Older participants were more hesitant. That is mostly due to them not really having access to technology all the time or advanced technology, while there was recognition that younger generations might be more receptive to a digital health solution. Participants acknowledged the potential of telerehabilitation to benefit future generations, provided there's adequate training and resources are made available to them by the healthcare sector. This research was important as it shows that while there is potential for telerehabilitation in South Africa, significant barriers must be addressed. Increasing awareness, improving the digital literacy, and providing adequate training are crucial steps towards a successful implementation of technology use. Investment in these areas, along with the management buy-in, is necessary to ensure technology use can be effectively integrated into our healthcare system, particularly in the more resource-limited settings. We do acknowledge that we had limitations where there was a small sample size of the 10 participants. It only included one condition, and it was limited to the public sector. Therefore, future research needs to be done in different populations and samples which are larger and more definitive. They must also be looked at different telerehabilitation service designs and models which are used globally, the effect of technology use on our health systems and different patient outcomes, and then just the feasibility of telerehabilitation delivery at the different levels of care in our healthcare system. And most important, we must look at the behavioral and educational interventions to address the perceptions and the attitudes of the different population groups and even the professionals. Yes.